Best greetings from here from Portugal for all of you, and hoping that everybody's okay and everybody is great and healthy and keep working. And situations that we have with the narrow ridge, very, very tiny bone, and how can we use some approaches to try to rehabilitate our patients in this kind of situations. So I'm going to share with you right now my computer, and starting the presentation basically with the consideration and surgical approaches that we may have. So basically, we have two approaches when we have a narrow ridge. Split by separating the bone. The choice should always have in consideration the following: the bone density and the bone dynamic, region of the procedure, because can the patient open his mouth enough is always one thing that we have to consider. The ridge between teeth, is there space enough for the cortical split procedure or not? The anatomy of the bone below the ridge, it's another consideration that we should always have in mind. And of course, the basic, that is the good oral hygiene, healthy and avoid smoking patients. It's always a very smart decision. Talking a little bit and very quickly about the general considerations. Everybody knows the bone resorption behavior, and we know when we have teeth and we know when we are losing our teeth, and what's happening with the bone when you using removal prostheses. We know the trauma that the removal prostheses can have on the bone, and we know with the aging of our patients that the bone is naturally going to resorb. And consider that we also know that the cortical is very dense and usually is very thin, but sometimes we have a cortical dense and very thick. And the cancellous is basically a majority porous and thick. So consider that this is the basic schematic that we know about the bone. D1, D2, D3, D4. Everybody knows that, but it's very important to keep in mind this sketch, because every time we are dealing with bone, dealing with implants, we have to know what kind of bone we are talking about. And we know that the D1 is compact bone, very dense. We know that the D2 is compact bone, very dense, with some cancellous, porous, and thick cortical. And D3, compact bone, very tiny and porous with thin cortical. And D4, spongeous bone with thin cortical. This is very, very important to keep in mind always, always. So in the schematic design, we can see basically how is the bone anatomically distributed. So D2 in the front, D1 in the front, D2, D3 at below, upper jaw is D3, D4, and the anterior upper jaw is D3, D2. So everybody knows this, but this consideration is quite important also. Determination of the bone density. We know that's according to the localization. We know that, and it's very important our aesthetic feeling, the densitometry through the CAT scan or CBCT scan. we can try to analyze according to the gray tones the several kinds of D type of bone. So we can say that the D1 type of bone is around 1,200 Hounsfield scale, the D2 800, the D3 600 Hounsfield, the D4 400. I can say to you that the enamel of a tooth has approximately 3,072 Hounsfield scale, and the air that we breathe, for instance, has minus 1,024 Hounsfield scale. So the density is very important for us to do some planning and the procedure planning of the installing an implant in the bone. Of course, the bone resistance and the bone density. We have to keep in mind that the D4 is always less dense than the D1. So the D1 is always more resistant than the D4. Quite important also for us to know which technique of drilling, for instance, we have to use. We are talking about the under drilling technique, or in some kind of bones we have to use the all-way drilling in kind of, for instance, for the D1 type of bone. So it's very important for us to know what kind of bone we are talking about. Another thing that is also important is the consideration about the elasticity model of the bone and some materials, for instance. And we know that the bone has a higher deformation and can easier be modeling, and when we are applying some tension on the bone, we know that the bone is going to deform. So according to the kind of materials that we are using and the location, it's important to know this also. And the elasticity model and the resistance, for instance. Here we know, of course, that the D4 is less resistance than the D1, for instance. So we have more elasticity model in D1 that we have in D4. This is also important for us to have in mind. Another thing is very important is the blood support. So because of the very high density that the D1 type of bone has, we know that we have normally low blood support. D2 is normally sufficient. D3 and D4 is normally a very high blood support. It's always important to know this because of the procedures also. If you are going to do a bone graft, we need blood support. It's always important to have blood support. If you are going to place an implant in a D1 bone, we know that you have very low blood support. Sometimes we have to wait a little bit of time to try to achieve some blooding inside the drilling area before installing the implant. So it's very important to consider always the blood support also. I'm going to show you a small video to introduce the acid kit, which is the one that I use to do the narrow ridge split, for instance. So I'm going to be quiet for 1 minute, only to present to you this kind of presentation video.
The acid kit. Cut a flap, making sure to leave 1.5 millimeters from the adjacent tooth. For method 1, use the crustal remover to make 3 grooves with 1 millimeter of space in between. For method 2, use the crustal remover to shave off the ridge to create a 4 mm horizontal platform, going on to create the 3 indentations upon the surface. For method 3, use the horizontal cutting disc to remove the top of the ridge, creating 3 shallow indentations upon the surface with the crustal remover. After commencing your choice of these 3 methods, use the guide drill to mark the center of these 3 indented spots. Go on to drill the area with the 2.8 diameter twist drill. Using the same horizontal cutting disc with a cutting depth of 5 mm, focus the sharp edge vertically and cut the mesial ridge, and then the sides. Keeping the same order, use the set drills to push into the ridge. Finally, use the torque wrench to push in your implant first mesial and then to the sides in countersink. Insert a healing abutment 2 mm higher than the soft tissue height on each of the fixtures. Suture and complete.
So considering this small movie that is very, very nice done, because it shows basically the 3 techniques that we can and how you can use the asset kit, I'm going to try to give you some examples of my approaches or my approach to several situations. So in this first example, for instance, we have a narrow ridge, but I consider it's a very difficult narrow ridge because it's only missing one single tooth, and this single tooth is in the lower anterior position. So it's a very difficult approach for surgical bone split because we had not enough space for using this kind of approach, like the asset kit, for instance. But in the beginning of this presentation, I told you that we have basically 2 ways of approach the narrow ridge, and is the difference between doing a cortical split when you can do it, when we have the conditions for choosing this approach, or in this case, in this example that I'm showing to you right now, when we have no space for that, for a bone split, and the option was to adding bone. So it's a bone graft procedure, and it's very important also to locate and to the position of this implant. And we are talking about a 41. It's a low incisor. We know that it's usually a D1 or D2 type of bone, and we know it's low vascularization and thin soft tissue. So we have a lot of difficult steps to try to overcome. So this is the initial situation of the lady, the patient, and how you can see it's a very, very, very tiny ridge, and no space at all to do another thing that is not that we have to do, of course, a bone graft. After open the flap and exposing the bone, this is when you can see really the bone that we have. It's just a little bit, so very tiny. It's a very narrow ridge, and the procedure was by starting to do some holes on the bone to try to create some conditions for we have a better bone graft and blood support condition, and after some small holes to provide this blood support and to provide this interact between the natural bone and the bone graft. We have put a screw, a vertical screw, and the objective of this is to try to do the tent effect. It's a technique that basically is to provide some stability to the bone graft and to provide some stability to the gingiva and to avoid the compression directly against the bone graft. So we have the screw to try to do the tent effect, basically, is this the situation. So the procedure was very easy after all, and we have put a collagen membrane, very fixed, put some bone. Over here we can use the technique of Eastern Urban, for instance, when we can do a mix between the xenograft bone and autologous bone, for instance. And after it's well compact, we just close the membrane and close the flap. And after that, because it's anterior tooth missing, so we need to put some prostheses over there. But we have to be careful for the prostheses. Try to not enter in contact with the soft tissue and the region of the bone graft to be more stable as possible. So we have cut the tooth on the middle, basically, for us to avoid the compression against the bone graft area. So this is the CBCT scan after the bone graft procedure, and you can see the screw, the vertical screw, and you can see that it's very fixed, the membrane, and 7 months later we reopen the flap and we are going to evaluate, and what we can see, it's a very nice bone formate, and we have plenty of bone. Probably it's not enough bone, but it's enough for us to place our implant. In this case, my choice was a one body implant of 2.5 millimeters. That is very well indicated for this kind of situations of lower incisors, or even for very tiny space after orthodontic procedures, for instance, when we have the roots which are very narrow and we don't have space enough. So this is an excellent solution for us to use in this kind of situations. After the implantation, I just have done a little bit more of bone graft with xenograft and close the flap. And on the same day, my choice was to put acrylic provisorium tooth on this implant. And this is the image of the provisorium. And the lady was quite happy, and she went, and after some time she come back. This is the image of on the same day of the procedure of the implant, and we have enough support right now of the bone, and this the position of the implant is very good, because it's in the middle of the distance where it should be. And 3 months after, the lady come back, as I was saying, and this is the image of the very nice and stable soft tissue around the implant, and we just have put a final crown. In this case was a metallic ceramic crown cemented with provisorium cement. It's quite enough for this kind of situation. And this is the final image And I think that we have done a nice job in this case. And this is one of the example how to what to do with narrow ridge. So in this case, it was a bone graft, and it was increasing the bone. It's funny because despite all this, she doesn't show the work, because the lady, when she talks, when she smiles, she never show anything about what we have done. Even so, it was an example for you guys to see. Another example is 2 teeth missing in the upper posterior position. We are talking about 24 and 25. No, it's a mistake. I think it's 25, 26, but it's the same localization basically. We have a medium difficulty approach for surgical bone split over here because of the localization, and the patient have to open the mouth. So, but it's medium difficulty. We have the need for cortical bone split, sinus lift, and bone graft. So basically, we have the need of 3 procedures on the same momento of surgical momento. The needs of cortical bone split, sinus lift, and bone graft. So the 3 at the same time. It usually is a D2, D3 type of bone with high vascularization and good soft tissue type. So that's one of the good things. And the bone dynamic is very favorable for bone split. And this is, of course, why? Because we are talking about the D2, D3 bone. So the higher it's the D, it's easier to do bone split. The lower is the D, it's better for stability, but it's worse for the dynamic of the bone. So the dynamic is it's very hard on the D1 bone, for instance. So this is the panoramic image, and how you can see this is all planning, and they are missing really the 25 and 26 teeth, and we are trying to do a sinus lift on that side. And this is the oral image, and when we open the flap, we can see the narrow ridge that we are talking about. So the procedure was basically using a disc to split the 2 corticals, and afterwards we have then a window, a lateral window to the sinus, and then we use the set drill to start pushing the bone. And when we're using the set drill, we are incrementing the set with in the width to push the bone a little bit more width. So after we use the steps for trying to get more width of the bone with this set, we can achieve a quite difference between the initial position of the cortical, the ridge, and what we achieve with the splitting. And I think it's a good image to try to elucidate everyone of what we could achieve with this technique. It's very interesting. After that, we put some xenograft in the sinus, and then put the first implant, which was a 3.5 implant. And when we're starting to put a 4.0 implant on the 26th tooth, we have a catastrophic fracture of our procedure. So the bone has fractured. I have to take the implant out, the molar implant, and afterwards we used a screw to fix and stabilize the bone fracture against the palatine bone. And with this procedure, we have a very nice stability. So in this case, we have done also a sinus lift, a bone split cortical, and a fracture stabilization. Okay, and this is the image after the bone graft and the sinus around the fracture, and this is the image that I want to show to you. We put a collagen membrane on top of the bone and close the flap. We waited some time, and in this CBCT image we can see on the left image we can see the stabilization of the fracture with the screw. On the right image on top, you can see that the initial bone width, we had only 3.4 millimeters, and after the procedure, we achieved to have almost 7 millimeters, 6.6 millimeters of width. So it was basically 100% increase of width on the bone. So I think it's very good, and we can see also the sinus lifts, bone graft over there. So we have the conditions to have some success over here. After a few months, around 6 months approximately, we take the screw out, and we can see very good bone formation of bone, and very stable and very hard bone. So it's it was a good procedure. We put the second implant, and after that it was rehabilitated with 2 crowns on top of implants. The comparison between the first image and the second, so between the beginning and the end. Another example, it was preparing 2 implants in the lower jaw for an overdenture. So in this case, what would we have? We have 2 teeth with 33 and 43 in place, but with periodontal compromise. We know that we have a medium-high difficulty approach for surgical bone split. The need for cortical bone split, we needed to do it in this case. And usually we know that in this region, we know that we have a D1 or D2 type of bone with low vascularization and thin soft tissue type. So, and the dynamic is very hard for bone split in this area because of the D1, D2. So considering this is the panoramic image, and you can see the compromise, the periodontal compromise, and the intraoral image, you can see also the periodontal compromise, and of course the narrow ridge when we are looking in an upper position. After extraction the teeth and open the flap, this is the actual situation of the bone. So we can try to intend to do a bone graft only over here, but because of the image of the panoramic, we know we have to do a regularization. So we start the regularization with cutting some bone around 6-7 millimeters of high to try to achieve a very plain surface of the bone. And after that, we are going to initiate our splitting using the disc. And in this procedure over here, my recommendation for you guys is try to have a very, 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 very nice and hard hand. Stabilize well your fingers against the chain or something, because it's always a risk when we are trying to cut with the disc bone. We have to be very sure that our hand is not going to go after the disc, because it's easy to have an accident against the lip or against the tongue. So it's very important for us to have a very precise hand and very secure hand. Okay, we have done the splitting, and then we have starting with the set drill to pushing the bone apart and to increase the cortical bone split. So we are only to put 2 implants in place, but we need to do at least 4 holes, 4 sides, where each side is going to help us to try to get more splitting, because the dynamic on this kind of bone, D1, D2 over here, it's a little bit more harder. So we are going to put 2 implants, but we need to do 4 holes at least to try to achieve without the risk of fracture of the bone. So it's easier when you try to achieve a bigger area to try to pushing the bone apart. So after the procedure, you can see basically what you could achieve with the set drill and the pushing apart of the bone. So this is the comparison between the beginning, the initial image, and the beginning of the pushing of the bone with the set drill, and at the end what we did really achieved with this procedure. And we can see it's a very nice difference. So we are able to install 2 implants of 3.5 diameter implants. It's good enough, and we know, looking at this image, that we have probably enough bone around the implants to be more or less secure that it's going to work very well. And over here we have the sequence of the image. And on the CBCT scan, on the left image, we started with 3.9 millimeters on the top of the bone, and we achieved at the end 6.9. So it was very nice. And on the lower set of the bone, we started with 4.9 and we have achieved 6.5. So we have a significant increase of bone by using this technique with the acid kit. So I was very happy. We didn't need any bone grafts for this procedure, and the case was solved. And this is the final X-ray. And over here you can put 2 locators, or in this case we use a bar, and to put some overdenture over the bar. And basically this was my presentation to you. And I finished this presentation with a sentence of Salvador Dali, when he once told us that, have no fear of perfection, you'll never reach it. So probably it's going to be true, but we are trying each day to reach it. So keep trying, keep pushing, and please keep safe. Okay? Bye.